This meeting is being recorded.
Hi, everyone. Welcome once again to Community Chats. My name is Sandra Arevalo, and I'm the Director of Community Health and Wellness at Montefiore Nyack Hospital, bringing you another speaker this week. And this time, we hit it off the stadium, as they say, because we have, nonetheless, Liliana Delgado, who is a nurse, a registered nurse, but most importantly, she's the director of the trauma program here at Montefiore Nyack Hospital. And Liliana, thank you so much for accepting the invitation to being here. One of the reasons why I invited her was because I had a personal interest in the topic. I'm like, you talk about trauma all the time, level 1, level 2, level 3, and I never understand because I just hear it. Right? That's what I said to you. I just hear it,
Yeah.
um, on the speakers, and I don't even know if I have to run or stay or what. What does it mean? So thank you so much for accepting this invitation. And Liliana, please start by telling us a little bit about more about you and your role and what you do here. And for our participants, our attendees, thank you so much for being here. Please use the Q&A, the chat, send questions, send comments. Let's try to make this a very and those two. I love when you guys send the hearts and the
The
thumbs up.
reactions.
It's so cute, like the reactions. Yeah,
I
that's
love
so cute.
that.
I love that. Yeah, please keep sending that. And now, thank you, Liliana, for being here. And please tell us a little bit more about you and your role.
Absolutely. No, and thank you for having me. I appreciate the opportunity. Something I definitely was looking forward to and need to do more of. So my background, I've been a registered nurse for 16 years. Pretty much my entire career has been here at Nyack Hospital, Montefiore Nyack now. I started off working overnight shift in an ICU step down unit. Then I migrated my way to the emergency department, and I was there for 14 years, and I was the nurse manager for 7 of those years. Then I took a little 1.5 year break from Nyack and went and I did the trauma program at another hospital. And now I am back to do the trauma program here at Montefiore Nyack. So I'm back home where I love. And I'm here to talk a little bit about the trauma program and what we offer to the community.
And Liliana, I know that you put a very nice PowerPoint together.
Yes.
So I'm going to invite you to share it by clicking the green button as we practiced before.
Yes. Okay. Here and here.
Perfect. Okay.
Okay, you
So
can see, right?
if
You see the big screen, just one slide.
yes, do you
Okay.
prefer to take all the questions at the end, or do you prefer that I read you the questions throughout?
You can ask as I go. I just can't see you now because I have the slideshow, but just feel free to let me know
Perfect.
the question. No problem.
I will. Oh,
All right, very good. So, trauma explained. And just to clarify, we are talking about physical trauma, not emotional or psychological trauma. But this is just a picture of our front of our facility here. So, the objectives for today's chat is to define physical trauma, explain what is the trauma system, talk about the different levels of trauma centers. I'd like to showcase Montefiore Nyack Hospital's capabilities, discuss the resources for the emotional aftermath of trauma, and show what the injury prevention program is. So, what is trauma? So, the definition from a dictionary for trauma is any physical injury caused by external force. Now, there's different types. There are blunt trauma, which is an injury caused by a forceful impact, fall, or attack with a dull object or surface. So that can be a fall, that can be somebody getting hit by a bat, that can be somebody getting hit by a baseball on the baseball field, or somebody in a car, sitting in a car, and the car crashes into something, and the steering wheel or the door hits the person on their body. Then we have penetrating trauma, and that is an injury where an object pierced the skin and enters the body. So that could be like a stabbing, a gunshot wound, or simply if you fall on glass and the glass cuts you. Anything like that is a penetrating injury. And then we have burns, and burns are self-explanatory. Um, but burns also encompasses explosion. So it could be from cooking. It could be normally it's from cooking, from either getting hot oil spilled or like a water hot water boiling that spills on you. But here at Montefiore Nyack, this is the statistics for our hospital. So the common causes for injury that come to Montefiore Nyack are 56% are falls. And like I said, that's the blunt trauma that we were talking about before. Motor vehicle crashes makes up 21% of the cases that we see here. Pedestrian struck is 8%. I'm sorry, 5%. And then pedestrian struck assault is, am I saying it right? I think I'm saying it wrong. Motor vehicles is 21%. Pedestrian struck is 8%, my mistake. And then assault is 5%. We get 5% burns. And accidents, that means a lot of things, but basically those are work-related injuries or crushing injuries or self-inflicted injuries. But that's basically what we see here at Nyack. And just a little bit about falls. So we have two different types of falls. We have fall from height, what we consider fall from height, and that's when somebody falls off a ladder because they were up cleaning like the ceiling or something, or putting up decorations. Usually that's a big one around the holidays. We have fall from the top of the stairs, or they missed a step halfway or at the bottom of the stairs. That's considered a fall from height. And then we have fall off a chair or a bed, which sometimes happens. And those are all considered fall from height. Then we have the ground level falls, and those are the trip and fall or slip and fall accidents due to like the rug, somebody tripped on a rug or a wet floor or an electrical cord, or they hit a toy and they fell on the floor, or a cracked sidewalk even. So all of those are the considered the falls. Then for pedestrian struck, for the most part, what we see is somebody was crossing the street and they were hit by a car. Usually not paying attention, looking down or looking at their cell phone. And then the other one that's very common is in a parking lot. So parking lot safety is huge for us. And those are low impact, so the cars aren't going fast, but they can still cause some damage. And then assault, somebody gets hit with something, or somebody gets stabbed, or there's a shooting. And then I was saying the burns from cooking hot oil or water are the ones that come in the most. Electrocution, I haven't seen many of those. And explosion, like from fireworks, haven't seen many of those, luckily. But those are the types of injuries that come to our hospital. Now, the trauma system. So overview of the trauma continuum. So it's not just Montefiore Nyack is a trauma center. It comprises the entire, from first responders to the rehabilitation hospital or a skilled nursing facility. So it takes a village to take care of a trauma patient. And I say that because first responders are the first ones that they're there. So when you call 911, the call goes out to the police and EMS at the same time. Police, there's usually more troops coming, around the area. So they're usually the first ones to arrive. Now they determine scene safety and access to the patient. So if the person is in a car and they can't get the person out, then they call the fire department. Or if there's a threat of fire, like a car fire, they call the fire department. Otherwise, they stay with the patient, and if there's any need for resuscitative efforts, they do that. Simultaneously, the EMS, as we call it, EMS bus, goes to the scene to see and assess the patient. And then you have the paramedics, which is a complete separate car from the EMS bus. And those are, the paramedics are the ones that are higher, they have a higher training than EMTs. They go to the scene and they're the ones that can provide different things, like they can put an IV, they can assess the patient, they can listen to their lung sounds to see if they need anything, any resuscitative efforts at the moment that the patient needs, and they start there. Then they call us, and the emergency department receives the call, and our job is to get ready for the patient and provide the initial resuscitation and stabilization. So if somebody has a broken bone that's like out of place, we put it back in place, we do the x-ray, we give the medications for pain and things like that. And then we decide if the patient has to go to the operating room. Is it an injury that's we're just gonna monitor and take them to the intensive care unit? Or is it an injury that we can't handle here at Montefiore Nyack because of the resources, and we transfer those patients to the level 1 trauma center, which is Westchester. And I'll explain a little bit more about all of this. This is just a basic overview. And then, of course, home. So what happens after the injury and you get the operation, or you go to the ICU, or you're in a medical surgical unit here at the hospital for pain control, then we start transitioning that patient to getting home, whether they go directly home because they're doing well and everything has been good, or they need to go to a rehab facility for a few days just to get them going to pre-injury status, and or do they need a skilled nursing facility if they're going to need a longer term of care. So the trauma program, the picture on the right with the gray, we call it the gray book. It's the resources for optimal care of the injured patient, and that is what we hold the hospital to the standard of. So, for example, any hospital can take care of any patient that comes in through the door. The difference between a hospital that becomes a trauma center, like we are, is that we're held to a higher quality standard. So if I don't know if you can hear, the verification review consultation committee. So the committee on trauma from the American College of Surgeons comes by every 3 years, and they do an in-depth look at our documents, our care, and they look at our call schedules, our medical records to see how we took care of that patient and if we're up to the standard that they're holding us to. So that's the difference between a regular community hospital and a trauma center. Is the level of care is higher. So the trauma program, my job here is to ensure that we are in compliance with this gray book, with the standards set forth by the American College of Surgeons Committee on Trauma. Their goal is to advocate for better trauma systems by providing education and establishing best practices for trauma care. So they focus on continuous quality improvement, outcome assessment, and ensuring optimal patient outcomes across the continuum of care. Basically, they make sure that we are doing right by the patient and that we are held to the higher standard and that the patient outcome is better than not being held to that standard. So basically increasing the odds of survival is the bottom line. So every trauma center at every level in this country abides by these standards. So if you hear of any hospital that they're, oh, we're a trauma level 1 center or a level 2 or a level 3, they all go by the same rules. They just have slight changes to the care that they can provide at their hospital. And I'm going into that next here. So like I was saying, all the trauma centers abide by the same standards set out by the American College of Surgeons, as well as the New York State Department of Health. So not only are we looked at by the American College of Surgeons, the Department of Health of every state also verifies and makes sure that we are doing what we say we're doing, basically. We all have a very robust quality assurance program. I look at every case that comes in through the door, and my trauma medical director does the same, and we make sure that everything is done right and it is done timely and that the patient gets the best care that they can while they're here. The other program that we participate in is the National Trauma Quality Improvement Program. So all of our cases that are considered trauma cases are put into this different registry where the ACS has access to, and they use that information and that data to not rank us, but to say this hospital's at 50% compliance with getting the patient into the operating room within 30 minutes. So now I have to make sure that I meet that or I'm better than. So they compare us all on a national level. So every level 3 trauma center is compared, and we use that data to make us better than the standard or the rest of the hospitals, I should say. We all have to offer hospital and pre-hospital staff education and training. That means that here I have some programs where I train my nurses, and the trauma medical director does programs also where he trains the physicians in the ER and the other trauma surgeons. But we also have to take that a step further and provide training to the pre-hospital personnel. So that means EMS. So we have a bi-monthly meeting with them where we present cases and we talk about the patients that they bring us and how we or they can improve on the care, or simply just give a kudos for a job well done. But if there's an opportunity that is identified, say, for example, we identify that a patient fell and there's a chance that they have a spinal cord injury and they didn't put the C-collar, the neck collar on that patient to protect that spine, then that would be something that we bring up to them and we say, listen, for every patient that comes in for a fall that there's a chance there's a spine injury, please make sure that they put the C-collar on the scene as opposed to waiting to put it when they get here, just to provide the patient the better protection. So that's part of also the trauma program. And then last but not least, we develop an injury prevention program. So as you saw before on the pie chart, most of our injuries are falls. So now my job is to go out into the community and do chats like these. And this is why I appreciate this opportunity to expand my injury prevention program. Most of our falls are geriatric falls, which means patients 65 and older. So now, for example, I have plans to go with the physical therapy department to go into the rehab facilities or the long-term care facilities and the assisted livings and provide a chat just like this and a presentation talking about what can we do to prevent falls. And accidents happen, falls happen, but if there's something that we can do to try to prevent it, something as simple as declutter your area or put a night light in your room so that your walkway to the bathroom is clear and has a light where you can see where you're going, or simply just to say, slow down, nobody's rushing, ask for help if you need help, just slow down. That alone can prevent a fall in our 65 plus community. So those are the things that all the trauma centers do and have. Now on the bottom picture here, you can see the different levels of trauma centers. And I'm just going to give you, on the right, you see the key features. That's basically the key differences between all of them. So Westchester Medical Center is a level 1 trauma center. They're the only level 1 trauma center in the Hudson Valley. And basically they have 24-hour in-house trauma surgeons and different specialties. That means that at any day, any given time, you have any type of injury, the surgeon that'll provide definitive care for that injury will be there. So that means that the trauma surgeon is in that trauma bay within 5 to 10 minutes of that patient getting in through that door. If they have an orthopedic injury, say somebody broke a bone in their leg and they need urgent operating room, the orthopedic surgeon is there to do it within a few minutes. Anesthesia is always needed for any procedure, so they're there. They have neurosurgeons in case there is a traumatic brain injury that needs intervention. Interventional radiology, that's a 24-hour service that they have also. Say you're in a car accident and you broke your pelvic bone and there's bleeding because there's a big artery that runs in our pelvic bone and there's a lot of bleeding, and to stop the bleeding you need interventional radiology. They are within reach there at the level 1 trauma center. Plastic surgeons, usually those are for hand injury or facial injury. So say you have a finger that was amputated during, a saw accident or something like that, you would need a plastic surgeon to re-put that finger back in place. They're there. And then oromaxillofacial surgery, if you have a very bad facial injury, say something hit you in the face and you have a fractured eye socket or it involves your eye, you have the surgeon there that can take care of that if they needed to. Along with that, the level 1 also has a pediatric level 1 trauma center, so they see and admit pediatric patients. And the only other difference is that they have a huge research department and they have an education program for the community. So that is a level 1 comprehensive level 1 trauma center. So that's what that means. A level 2, and the nearest one to us is Mid-Hudson Regional Hospital in, I think, Poughkeepsie, and they have 24-hour immediate access to a trauma surgeon. And what the difference between in-house trauma surgeon and immediate surgeon access is that the surgeon doesn't have to be in the hospital per se, but they need to be in that trauma bay within 15 minutes, which pretty much means that they are in the hospital 24 hours. And then the other specialties, they need to have, the ACS requires them to have orthopedic surgeon, anesthesia, neurosurgery, and interventional radiology with access, not in-house, but access. So that means that if you go to, say, Mid-Hudson Regional and you were in a bicycle accident and you broke your leg and they need an orthopedic surgeon to do immediate surgery, they can do that at Mid-Hudson Regional because they have access to the orthopedic surgeon within a few minutes. Usually it's like 30 minutes or less. Now the level 3, which is what we are. Oh, and one more thing about the level 2. The cases that they cannot manage at the level 2 because they're not required, for example, they're not required to have a plastic surgeon on call or an oromaxillofacial surgeon with immediate access, those are the patients from the level 2 that get transferred to the level 1, because that's where those physicians are, those surgeons are. Now for us, we are a level 3 trauma center. The ACS requires us to have emergency physician in-house 24/7 at all times in our hospital, which we have. And a plus for us, we're not required to have an anesthesiologist 24 hours in-house, but we do. So that's a plus for us. And then the trauma surgeon access, again, within 30 minutes. So a level 3 trauma center, the American College of Surgeons requires us to have a trauma surgeon in that trauma bay in the emergency department within 30 minutes of that patient arriving. And if that patient has to go to the operating room, we get them there within 30 minutes. So those are the different things the different levels of care, let's call it, that differentiates us between a level 1, a level 2, and a level 3. So Montefiore Nyack Hospital and Montefiore St. Luke's in, I believe, Cornwall is the other level 3. And also that we have transfer agreements with the level 1 center. So that means that a patient comes in that needs emergent OR for, say, an eye injury or again, a pelvic fracture that's bleeding that we can't handle here. Now, this is not to say that we don't have an orthopedic surgeon and interventional radiology. We do have those surgeons and we do have that capability. But there are times, like say 2 o'clock in the morning, where those surgeons are not immediately accessible. So then that's why we transfer those patients out. So those are the key differences and key features of the different levels. Like I said before, any injury we can handle, any injury we can take care of. It's the amount of time to get that patient the care that they need. Anybody can come in here with any orthopedic injury. We have orthopedic surgeons on call. And as I told you, we have anesthesia in the hospital 24/7. So if we needed to get somebody to the OR, which we have before, we have had some middle of the night accidents where we need an orthopedic surgeon to say, an ankle fracture or an arm or any type of injury. They are here to do that and they will come in to do these procedures. It's the ones that are more complicated, like where they need an orthopedic surgeon and they also need a vascular surgeon. Those are the ones, without a doubt, that we send to Westchester. And in a few more slides, I'll show you more of our process, but we can get that done in less than an hour. We can see a patient stabilized and send them, and they can be at Westchester even within 30 minutes. And it has happened before. We have had cases where we have had that happen. Now, like I said, being a trauma center holds us to a higher level. And it just means that the American College of Surgeons comes and they're monitoring and they're making sure that we're doing what we say we're doing. And that's also my job, is to make sure that the quality assurance is being done. I can tell you, we just got the final report yesterday. We had our visit in May. The American College of Surgeons came to our hospital. It was a 2-day survey. They reviewed our medical records. They reviewed our documents. They looked at our hospital. They went to the ambulance bay. They spoke to the ambulance leadership, like their EMS staff. They went to the emergency department, the operating room, the ICU, the PACU, the post-op care unit. And they were very impressed. They were impressed with the commitment that we have to trauma care. They spoke to all of our surgeons in the community that take trauma call, the ones that take orthopedic call, the critical care team that we have here, which is also 24/7. We have a critical care physician in-house 24 hours. So anybody that's being managed in the ICU, the physician is here in-house, and they actually round on the patients on the daytime and on the nighttime continuously. So those are all pluses that we have here at Montefiore Nyack. And as I said, the ACS came in May. They looked at our facility. They spoke to our staff. They spoke to our surgeons, our physicians. They were impressed by the teamwork. I know for certain that the teamwork is great here with the surgeons and the physicians. And they just sent us our final report yesterday. And they said that we are verified as a level 3 trauma center for the next 3 years with no acute findings, which means that we did good and we showed that we did good. And we're going to continue our trauma care as they hold us to that standard. So now this is our meet our trauma surgery team for Montefiore Nyack Hospital. We have Dr. Simon, Dr. Fleischer, Dr. Fugue. Dr. Racklin is our trauma medical director. So he's the one that works very closely with me and makes sure that we have all of the documentation and the care is up to the standard that the ACS requires. Then we have Dr. Kronfeld, Dr. Barsoom, and we have a physician assistant who is here, I want to say Monday through Friday. Business hours, she's here and she rounds on these patients. But I can tell you, Dr. Racklin is here 3 to 4 days. There's always a trauma surgeon at the hospital. So if there's ever a trauma that needs taken care of during the daytime, they are here up until at least 7 p.m. After that, 30 minutes, they will be here. We have a very dedicated team. I can tell you for 2024, since I pull all the statistics, we had 45 level 1 trauma activations. Those are the ones that need the surgeon in the emergency room within 30 minutes. 98% of the times that surgeon was there within 30 minutes. That means 44 of those 45 times the trauma surgeon was in the emergency department, in the trauma bay, seeing the patient, assessing the patient, touching that patient from their arrival. The 2% or the one case that fell out, the surgeon made it within 35 minutes. So he was 5 minutes shy of meeting the 30-minute standard. However, that particular case, we had no pre-notification. So EMS didn't call us and tell us they were coming. It was an accident nearby, and they just came in without calling. So that 5 minute could have been taken down by that pre-hospital notification. But again, we don't always have pre-hospital notification, but 98% compliance with the 30-minute standard is amazing. And when I say the ACS was impressed, that's why they were impressed. These surgeons are committed to trauma. They're dedicated. They're a dedicated team. If one can't come, the other one will. So that's a plus for us. Now, our community trauma response. So as I said before, it takes a village, and it really does. So from the minute you get into that car accident to the minute you're discharged and sent home, that's the trauma response in the community. So again, just some pictures to depict here. So we have a car accident that happens. You call 911. First responders arrive at the scene of the accident. They assess the situation, and they call the hospital to let us know that they're bringing a patient. They start care immediately in the back of their ambulance, and they bring the patient to the emergency department. Again, remember before I said there's the EMS group, right? They're the big bus that brings the patient. And I said the paramedics come in a separate SUV. Well, that paramedic joins that patient and comes in the ambulance bay, in the ambulance truck, to the emergency department. Now, our job when we get that call, we activate a code trauma. So that when we say trauma level 1 or trauma level 2, that just depends on what injury patterns. And the ER has the different criteria that the patient would meet. So say a level 1, which is the one where the surgeon needs to be in the room with the patient within 30 minutes of arrival. So the trauma team prepares a trauma bay. So the trauma team is made up of the ER physician, the 2 ER nurses, and the 1 patient care tech that work in the emergency department. They prepare the equipment, they get ready for the patient. They clean out the room, they have the room ready for the patient to come in, and we can start care. Now, part of this is anticipating what the patient needs. If the ambulance personnel calls us and say that they have, for example, a patient that was in a car accident and has, or say motorcycle accident and has multiple wounds all over their body, and they're bleeding and laceration on the head, and they have a broken bone, we know we're going to need heavy bleeding materials ready for that patient. So we take our cart, our bleeding cart, we open it up, and we have everything we need there to stop the bleeding right as the patient gets there. This is all done before the patient gets here. And then also the trauma surgeon is called to the trauma bay. Ancillary services. So the ancillary team is made up of the x-ray technician, and his or her job is to bring the portable x-ray machine into that trauma bay before the patient gets there. Then we have the CAT scan. The CAT scan is connected to the trauma bay in the emergency department. So it's 10 steps away from the patient when they get here. So now their job, for the CAT scan tech's job, is finish up whatever CAT scan they're doing, not take any more, and stand by until we get this trauma patient in that room. So they hold the CAT scan table for that patient that is coming in. Then we have a transporter. So this is a person that comes to the trauma bay, and whatever transport needs we have at the moment, that's their job. So they stand by and wait for us to tell them what to do. It's like an extra hand for any movement that we need. the blood bank is alerted and they start setting up the blood. Say, like I said before, say this person is bleeding. We have the bleeding equipment to stop the bleeding, but we also need blood to replace the blood that they lost. So the blood bank, the blood bank in our hospital gets 2 units ready. They put it in a cooler and they have it there ready for when the patient gets there. We pick it up, and within 10-15 minutes, if that patient is bleeding out, we can get them the blood. Then we have registration. That's super important, right? Patient identification. Patient comes in, the registrar is at the door. They get the person's ID, or if they don't have the ID, then the family member is there and they can validate, or the person can say, my name and date of birth is such and such. They register the patients. Within 2 minutes, that patient is registered, and that can start the treatment process with the blood coming to us, because we need to identify patients safely, get the blood that they need safely, and that's part of that process. So the registration process. Then we have security who stands by in the ER at all times. But now when a trauma is coming in, depending on what the trauma is, we might need crowd control. We might need to secure the area. If it was like a gunshot wound or a stabbing, that usually means there was something going on outside of the hospital, and there's a chance that that person can come back and quote unquote finish the job. So security's job is to make sure that the ER is secure, the staff, the patient, and the area is secure, and like I said, crowd control. And also, concerned family members. If there was a car accident, there's going to be another car behind, usually, or the family's on their way there. Security is there to make sure that they're safe and secure, and when we have the patient, they can come into the room and visit, but at least that they have an extra person there as a layer of protection. Then the nursing supervisor, or as well as the operating room nurse, comes down and waits for the patient, and anesthesia also. So everything I just described as the trauma team, when EMS calls us and says we're bringing this type of patient in, and they fit the criteria to be a trauma level 1, we activate the level 1, and all those people I just mentioned come to the trauma bay to wait for that patient. So we have everything that we need when that patient gets to the room. Now, patient arrival. Patient gets into the room. EMS gives us our report. They tell us what went on with the patient, what treatments they did. We put the patient on the stretcher. EMS steps aside. We take over. The nurse starts putting, whether it's IV, they start taking blood, they start giving medications, IV fluids. The doctor does their assessment and tells us what to do. So now, by this time, the trauma surgeon is in the room. So now, between the trauma surgeon and the emergency physician, they assess and decide on what treatments we need. They can tell us, draw labs, give medications, give IV fluids, and we're the ones that carry that out as a nurse. And like I said, the ancillary team, the x-ray is being done right then and there. This is all happening simultaneously. This is now step by step. This is simultaneously. The nurse is putting the IV to give the IV fluids. The doctor's making their assessment and telling us what to do. The x-ray technician is getting the x-ray ready to get a chest x-ray on that patient. The trauma surgeon is doing the ultrasound in their stomach to see if they're bleeding and we need to give blood right away. Everything is happening all at once. Now, once the patient is assessed and we're like, okay, they're stable to go to CAT scan, they go to CAT scan, which, like I said, is 10 steps away. Then after the imaging is complete, the trauma surgeon will say, this person needs to be transferred, this person needs to go to the OR emergently, this person can go to the ICU, or this patient can go home because they're fine. So that's then where the decision-making and the disposition is made. So now, all of that happens fairly quickly, and it happens because we're prepared, because we're held to the standard, and the ACS has these guidelines that we go by and best practices, and that is how we know that we're providing the best level of care that we can as a trauma center. So that's what the community trauma response is from the beginning all the way to end of the ER care, and then they get admitted, and then we see what happens after that. Whether they, like I said, stay for observation, or they go to Westchester, or they go to the operating room right from the ER. Next, so after the trauma, so trauma isn't just physical. There's emotional and psychological impact. So you can imagine after having a life-changing event, say there was a person that came in a few years ago that was standing on their car with the car door open at a car wash, and the person cleaning the car, or something happened where they didn't know and they slammed the door shut. and the person's feet were outside of the car and the person was inside. So you can imagine that's a life-changing event. Bilateral foot amputation. I think they were able to put one back, and the other one we weren't able to save. But that's a huge life-changing event, right? So there's shock, there's fear, and then with that comes post-traumatic PTSD, right? Post-traumatic stress disorder. That can happen when any type of trauma somebody has. If it's an elderly patient that came in for a fall, let's just say, and they broke their hip, that's a life-changing event. So there is some emotional and psychological impact after the trauma, but we don't see it right away. We see it after. So because of that, we have screenings for these patients. So every patient that gets admitted to Montefiore Nyack gets a patient safety screening, which is a suicide risk screening. They get depression risk screening, which every patient, there's like it's a questionnaire interview that they do for every patient to see if there's any depression. There's a functional change or decline in screening. The CAGE 8 is the alcohol abuse screening that we're required by the ACS to do on our patients. And then also the PTSD screening, that's something that I am going to implement in the coming months. But basically what we do is see if these patients need any extra help or assistance. And as a institution, we have the resources available here. So the resources we have are social workers, we have nurse case managers, we have behavioral health social workers and behavioral health counselors. So any of these screenings, right, that I just mentioned, we do them when the patient is admitted. So say the patient came in for the injury and they go to the operating room, they go to the intensive care unit, and while we're trying to rehabilitate that patient and they wake up and we do these screenings. Any of these screenings come out positive, we provide the resources that they need within the hospital. So we connect them with the inpatient team. So whether they need a psychiatrist, we have those in-house, a psychologist, whether they need just a social worker or a counselor, or if it's an alcohol abuse situation, we have an inpatient alcohol rehab unit here. So whatever we're screening the patient for, we're providing the resources for. If it's a functional change, say that, they're going to need a walker now to walk, or they need a cane to get around, or crutches for whether it's they need it right now or they're going to need it in the future. We have physical therapy in-house that will see the patient and work with the patient. But basically, when I keep going back to the ACS and the standards that they hold us, this is part of the standard that they're holding us to. They're making sure that we are providing the care to these patients in the trauma bay and beyond, right? So now we admit the patient. Do they need help getting around? Yes. Okay, we give them physical therapy. Are they going to need help with, there's a higher chance of them being depressed or there's a suicide risk? Okay, we have behavioral health counselors and psychologists that will see the patient while they're in the hospital. After they leave here, the case managers, they connect them with the outpatient centers that they need for whatever resources that they need. So these are the things that we are held to the standard by the ACS to provide for our patients. It's the services that we have currently for our patients, and we monitor and make sure that these patients follow up and follow through with the care that they need, should they need any of these. Now, is that to say that every patient needs it? No. Some patients will come in, they screen negative on all of these screenings. We still provide physical therapy. We still provide social workers and case managers for the patient. But do they need extra after they leave here? No. If they don't, great. They go home. We give them written resources just so they can have it. But it goes both ways. You either need it or you don't. If you do, we have it. If you don't, we still offer and provide it. But if you don't need it, you don't need it. Right. So that is the continuum of care for trauma care. And it ends never. We have the injury prevention program that I am expanding currently, and then community engagement. So like I said before, we're going to start going to the senior centers and doing senior fall prevention and safety chats. We're going to begin to do helmet and seatbelt safety. We're probably going to connect with the local police and fire departments because they already have that kind of program, so we can just help them kind of expand on it. Pedestrian safety, like I said before, 8% of our patients are pedestrian struck. So a lot of the pedestrian safety, whether it's written or we can do chats like this one, teen driver education, going into the schools to provide education for teens on teen driver safety. And then safe swimming. We go to daycare centers. We can go to even preschools and talk about swimming, and even the camps, summer camps. That's something that we can offer to the community, and that I will when I start building it more, the injury prevention program. Again, community support. There's a lot of events in the community that I know through Sandra, like the ones for the senior safety ones. There is, I'm forgetting all of them. I should have written them down. But there's at Rockland Community College, there is the, Sandra, what is it called? The Teddy Bear Hospital, where we go and we talk to the children, right, about safety. Then there is at the Boulder Stadium every year, they have another huge event for senior citizens, and that's where we go and talk about senior fall prevention strategies. And then again, just a lot of outreach in the community as much as I can. And like I said, this is all required by the ACS, but it's also doing right by the community. And it is something that I am more than happy to do and team up with whoever I can to provide these educational and training sessions to the community. So that is what is required. Now, I do have a real case scenario of a patient that came in and the trajectory of care, just so you can see how we can connect the patients from beginning to end. So we had a 78-year-old female calls EMS. The family calls that the patient fell down a flight of stairs. EMS gets there. They find the woman that is slightly confused. She has a laceration on her scalp that is bleeding. So, of course, they patch the bleeding. They stop the bleeding. And they call the emergency department, and we get ready. We activate a level 2 trauma. So now, MD evaluation, just a disclosure. The pictures that I'm showing, they're not our staff. This is images that I got from Google. These are not real people in our ER. So the MD evaluation, so the ER physician is in the trauma bay, waiting for the patient. Patient comes in. She's alert, she's awake, she's moving all extremities. She is confused about the date and time, and she does not remember falling. There is bruising on the left side of her chest and some crepitus. Crepitus is when air gets underneath the skin, and it feels crackly like rice, and it sounds like Rice Krispies. So imagine your chest is supposed to be flat, and between under the skin, you feel like a bubble, almost like a balloon, but smaller, and it feels crackly. So that's what crepitus is. So he assesses the chest, and that's what he finds. Her heart is normal. He listens to her heart. It sounds normal. The abdomen is normal. It's soft. It's non-distended. He does the ultrasound of the stomach to see if there's any bleeding. No bleeding. Patient does not complain of back pain or neck pain. And the arms and the legs are fine. And just of note, the patient does take Eliquis, which is a medication used for atrial fibrillation, and it's a blood thinning medication. That's important for us to know, because if the patient takes a blood thinning medication, that means their chances of bleeding are higher. So now with the assessment of the patient is confused, it kind of makes us think about brain injury, right? So that's why this is all important. Now, all of this is accomplished within 15 minutes of the patient's arrival. Next, so I put the times in pink just so you see the timeline of events. So the patient arrives to the emergency department at 5:22 p.m. The physician is in the room. He does his assessment, as I said before. The chest X-ray is done right at the bedside. So within 9 minutes, the chest X-ray is done. So 5:31, the chest X-ray is done, and the physician is right there at the bedside, and he looks at the image and shows broken ribs on the left side with a small pneumothorax, which is a collapsed lung. Patient gets what we call PAN scan. It means it's a full body CAT scan. That means the patient gets a CAT scan of their brain, their neck, their chest, abdomen, and pelvis to see if there's any abnormalities. And in this case, for this patient, it was all negative and normal. Actually, no, it was not. The pelvis was normal. The abdomen was normal. The neck was normal. The brain showed a small bleed. So the patient however she landed on the floor, she hit her head, and the bang caused a small bleed in her brain. And the CAT scan of the chest shows the 4 broken ribs on the left side and a partially collapsed lung. So we already saw this on the chest X-ray, but we need to get a better look at it, and that's why we do the CAT scan. Again, Within 30 minutes, all of this was done at 5:40. So the patient got to the emergency room at 5:22 p.m. At 5:48 p.m., all the imaging was done and all of these diagnoses were done. So that's a good, 26 minutes. So within 30 minutes of the patient's arrival, all of that is done. Trauma surgeon sees the patient at 5:57 p.m. And these times are all quantified by the time that is documented in our medical record. So the trauma surgeon, actually, no, not the trauma surgeon, the scribe nurse, the one that writes everything down of what's happening, documents all the time. So at 5:57 p.m., the trauma surgeon is at the bedside. He sees and evaluates the patient. The neurosurgeon, the on-call neurosurgeon, we call them and we discuss the case with them. And all of the patient's injuries, none of the injuries, the ribs and the brain bleed, require surgical intervention. So had the bleed been bigger in the brain and caused more symptoms with increased intracranial pressure, that neurosurgeon would have been on his way here and in the operating room probably within 30 minutes. So then now, like I said, between the neurosurgeon and the trauma surgeon evaluation, patient does not need to go to the operating room, but we do need to monitor the patient. So the patient is admitted to the hospital, goes to the critical care unit. She's in the unit by 6:58 p.m. This is roughly an hour and a half after arrival. So see how fast the time is. And that is, again, all because we're holding our staff to that standard. And these are the things that I monitor on a day-to-day basis. I look at when the patient came in and I extract from the medical record all these times. And if the times are prolonged and I see that there's an issue, I bring it up and we discuss it and we try to fix it. Or we do fix it. We don't just try. So this patient in particular, she went to the ICU. She got some medications to reverse the anticoagulation, which means the Eliquis that she's taking to thin her blood. Obviously, we stopped giving her that medication, but we gave other medications to make the blood not as thin as the Eliquis would, because it would make, for example, the brain bleed get worse. So we give reversal medication so the bleeding doesn't get worse. Her repeat CAT scan, because this is part of the plan. Now, the neurosurgeon said, get a new CAT scan in 6 hours and again in 24 hours just to see the progression of the bleed. Her subsequent CT, 6 hours after the first one, shows that the bleeding is stable and her neurologic status has not changed. So she's still slightly confused, but she hasn't gotten worse from when she came in and the bleeding stopped. Now there's also a repeat chest x-ray because remember she has those broken ribs and collapsed lung. And the treatment for that is just oxygen, monitor, and pain control because rib fractures are very painful. And also this device called the incentispirometer, which helps her deep breathe to make sure that she can expand the lungs back up to normal. So the repeat chest x-ray that was done later that evening or that night is not getting any worse. So her lungs are doing okay. They're not getting worse. And then again, the bones, they're fractured, but they are not displaced. They're not causing any more collapsed lung. And the treatment for that again is pain control. Now, had she had more than 6 or 7 rib fractures and they're moved, the fractures actually moved and it can puncture her lung, she would have had to go into the operating room for that to fix it. But in her case, she did not need that. So while the patient is here and providing pain control for her, we're monitoring her neurologic status and making sure that she's still awake, she's not losing function, she can talk to us, her confusion is getting better, her ribs aren't impeding her from moving around. As you can imagine, there's pain. She's not going to move around as much, so we get physical therapy to see the patient while she's here. All the screenings were done and they were negative. The psychological and emotional screenings that I was talking about earlier, all of hers came back negative. And her neurological status improves and she goes home in 3 days. So this is from beginning to end what we do for our patients here at this hospital. And the standard that we're being held to is making sure that the patient's outcome is survival. Now, again, the trauma surgeon response, the neurosurgeon response, the medications that she's giving, the chest x-ray, CAT scans that are all done initially and then repeated, those are the standards that I look at every day and make sure that we're following. And as I said before, if we're not, it's something that we have a discussion about. I go and I speak to radiology, I speak to the emergency department, my trauma medical director speaks to the surgeons involved or the physicians involved if there's any issues, and we pick out the issues, talk about them, and we fix them. So that's what a trauma center does from beginning to end. And I think, yeah, that's the end of my presentation.
That's beautiful. Thank you so much.
Oh, of course.
Well, thank God we don't have to go through this every day because it's so
It's a
crazy.
lot.
I mean, it's a lot of what you guys do. And, I was impressed when you were explaining how many things are you already doing at so many different levels and the patient is not even here.
Yes.
It's
It's a lot.
unbelievable. It is a lot. So thank you so much for this
Of course.
explanation. Now
Sure, that's
I was listening to you and thinking about like the ER in TV, like it's so different than
so
the
different. So
reality.
different. What you see on TV is not what happens. All
Oh
that
no.
banter and chatter, and that doesn't happen. We see the patient, we assess, and what are we doing?
Yes. So a couple of follow-up questions for you, Liliana.
Yeah.
You mentioned blood transfusions, which obviously during a trauma that can happen, but then there are some people due to religion or other reasons that they do not allow blood transfusions. So what do you do in those cases?
We give them IV fluids. So blood has a lot of different components in it. Red blood cells, there's plasma, there's a lot. So the purpose of giving the blood is to make sure that the patient is replenished and their blood pressure stays where it's supposed to be. If the patient refuses the blood, we don't force it, obviously. We give IV fluids. There's fluids that we can give that have some of the components that are in the blood that can replenish the blood. And then we try to see what other treatments and medications we can give as opposed to blood.
Now, if the patient comes to the hospital and the patient is unconscious, a few questions. How do you know which medications the patient is taking? Because you said,
You
for example, in the case of this lady, you knew the patient was taking Paxil, but if they're unconscious, you don't know, what do you do?
You don't know. You treat with what's in front of you. You do what's right for the patient at that moment.
Wow, that's hard. That must be very
It is
hard to do. It's like you're
it is
basically operating with a bandage in your eyes.
exactly.
So that's why we always say you have to carry a list of medications with you.
Yes.
Everywhere we go, that's the first thing we say. You have to carry a list of medications with you because God forbid something like this happens. We need to know because otherwise.
I mean, listen, and technology is very helpful. We have our cell phones. We have that medical alert in our phone now. If you put it there, EMS is trained. If they see an iPhone, they press the button and it says, I think it asks if you want to see the medical information. It's on there and it'll list without unlocking the phone. It brings up the screen and it shows allergies, medications, history, emergency contact. So if you're not going to have a little card in your wallet, you can have it on your phone. And patients also have the bracelet. So the people that refuse the blood, a lot of times they'll have the bracelet.
Yes.
Or it'll be in our system because they've been here before, or in their phone, or a little card in their wallet. So there's ways to safeguard us and for us to check these things. But not everybody every time uses it.
And there are some people also that have those bracelets that say diabetes or high blood pressure. I think that's very important. I mean, we never know. We really never know. I think that's an investment on our life, really. It could save a life. Okay. And then what about contacting family? Because then again, if it's an accident, for example, the patient is unconscious, who does that? How does that happen?
The police. So we do everything after. We take care of the patient here, but we don't attempt to contact anyone unless the police officer, but they're the ones really. They find the next of kin and they're the ones that go and, to the houses or whoever, and then they tell us who the family member is.
Oh, okay. Very, very nice. I mean, it's
good
it's beyond the hospital, right? It's like you have a whole community.
Our first responders, police, EMS, fire department, they're the ones that connect us to the community. So yes, the patient is here, but whatever we need, they're the ones that go out in the field and get the information. So very important to have a good relationship, and we do.
Yeah, oh my God, that's amazing. I love
Yes,
that. Well,
yes,
I'm community. What do you want to expect?
yes,
So of course,
exactly.
I love whenever I see collaboration in community and all of that. That's
Yeah,
wonderful. Thank you
absolutely.
so much, Liliana. This
Of
was
course,
so enlightening.
anytime.
I've always had a lot of respect for people in the ER, but now I think it's growing even more. So
Yes,
it's to
thank you.
you, and I'm sure the people who are gonna be watching this recording, they're gonna be like, "What? No, this is not the ER
All the work,
that
and
we're
they
used
have
to
no
see."
idea. Yes, there's a lot of work behind the scenes that not everybody knows. So I'm glad I can get the word out
Yeah.
so people can see
Well,
there's a lot of preparation and things that we do, and training. Oh my God, training
yes.
every day.
Yes. Well, thank you, and the whole team and all first responders for
Of course, you're very welcome, and we'll
that.
be back with fall prevention
Yes, we
and
will.
other
So thank you
safety
so
training.
much. And thank you, obviously, to our attendees for being here, for paying attention, for learning with us. And I'll see you next week. Next week, we have, dealing with cancer diagnosis. But we're not going to talk about the patient with cancer. We're going to talk about the caregivers because, I like to say that cancer is not just for the patient. When a person gets diagnosed, like the whole family gets diagnosed, it affects everyone. So
Very
we're going to be talking about how to take care of the caregivers as well. So join us next week, 12 p.m. See you then.
Very
Thank you all.
Thank
Bye-bye.
you.